Hello, and welcome to the Ovarian Club, a glimpse into conversations between two besties across countries, South Africa and France, tackling the trendiest women's wellness topics through a scientific lens.
Join me, Dr Tarryn, and health expat Emma as we explore delicate subjects related to the women's health space.
We started this podcast to share our conversations to help navigate the complex women's wellness world. We hope you enjoy the podcast and take away as much from it as we've enjoyed making it.
The Ovarian Club, powering life, nurturing health, shaping sustainable wellness. So, my follicle friends,
let's begin. How's it, Ta?
How's it, follicle friend? How are you?
I'm good. I'm doing all right. How about yourself?
I'm good. I feel like you're never going to get over this follicle friend line. I always see you cringe from across the camera every time I say it.
I'm never going to get on board with it. It's not gonna. It's like, stop trying to make, what is it? Stop trying to make fetch happen. Yeah.
Well, I don't know. The fans love it and I love it, and follicle friend it is.
I think we should do a poll on it as a story next time. Like, who actually likes the word follicle friend? Who doesn't?
Okay, that's fair. That's fair.
But I know we have quite a deep conversation to dive into today. So it is Breast Cancer Awareness Month. And I remember I was telling you about it and being like, it's October Rose and a rose and everything like that. And then I just realized that's just the French name and I translated it in my head. But it is Breast Cancer Awareness Month, an exceptionally important month. And actually the awareness drive that this month has done and everything that has led to early screening, that has led to people actually doing self-testing, the steps and following the measures to make sure that they're doing early screening has saved a lot of lives and has reduced quite significantly the burden of disease. So I'm very much looking forward to digging into this topic with you and just really understanding and exploring and breaking it down for our listeners in terms of, who's at risk, what are the risk factors. I mean, when I was going through the risk factors, they're just wild, they're insane. So before we do dig in, there's some kind of things that I think is quite crazy. I mean, in 2022, I think it was that there was 2.3 million women diagnosed with breast cancer. And the differences in terms of how many women actually survive breast cancer in developed countries versus those in developing countries, especially South Africa, it's insane. I think it was something like only 40% survival rate, if I'm not mistaken, in South Africa. So this is a hugely important topic, and I'm so grateful that we're here today to discuss it. But before we do dig in, just some disclaimers. The views expressed on this podcast by no means, shape or form express the views of the company I work for.
Yes, and just a quick disclaimer on my side, although I'm a qualified medical doctor, this podcast does not serve to offer any personal medical advice, so always seek the advice of a healthcare professional with regard to any condition or treatment you may be seeking. Just to reiterate what you were saying, I mean, the stats are pretty wild. And breast cancer, I mean, as I'm sure many of our listeners know, it's the most commonly diagnosed cancer in women. And it's sadly on the rise, which is quite alarming. I mean, despite all the amazing screening methods we have today, something's going wrong. We're picking up cases really, really late. They have high mortality rates if picked up at its late stages, which is commonly the case. And it's just really, really important to raise awareness on this really important issue. Patients ought to know the early symptoms, like what to look out for, what screening methods are available to them. And definitely we should chat through all the risk factors and really just dig into this topic today in light of October, the Breast Cancer Awareness Month. So I'm excited to chat to you today.
That's interesting you say that, because my understanding, I did just a bit of reading. Of course, you've done a lot more research than I have. My understanding is that there's still obviously a very high mortality rate. There may be actually an increase in terms of the incidence or how many people are getting breast cancer. My understanding was that due to kind of earlier screening, prevention, awareness, that in especially developed countries, again, South Africa is a different situation and quite significantly behind in terms of other countries, but that actually less women are dying from it because of early prevention, early detection. So interested also to kind of dig into that. But let's start with understanding who is at risk of breast cancer. And I know that we've covered off some of this in our previous episode on genetic screening, BRCA1 and 2, the different genetic mutations. So definitely go listen to that episode if you haven't had the chance to listen already. But when I was going through the risk factors, I mean, they're pretty wild. I mean, like, hormones certainly play a big one. Love to try and understand. There's a lot of talk about the impact of the pill, the different fertility treatments. Alcohol was one that really shocked me as a huge risk factor. Any alcohol consumption, actually, not just, if you're an alcoholic or high consumption, any alcohol consumption, weight, childbirth, having like children after the age of 30, or not having any children at all. So
yeah. It seems like you've already done all the research. I don't know what more to add, but yeah, we can definitely tap into to the risk factors and maybe explain the mechanisms. And I'm also super keen to tap into hormones because it's a question that I commonly get asked. But having said that, I also want to maybe put the pill aside as like a completely separate episode because there's a lot to unpack there. But most certainly we can chat through where the current evidence stands with regard to risk of developing breast cancer. So yeah, I mean, MU largely touched on most of them, but genetics is an important factor, although it actually counts for only 10% of cases. So 90% of the time it is actually due to lifestyle. And that's not to put the blame on anyone. And it's also to say that even if one does have risk factors, it doesn't mean that you're going to develop it. But obviously the likelihood of developing it is increased. But when it comes to genetics, BRCA1, 2, that's that episode we touched on previously. One could say genetics loads the gun, but lifestyle pulls the trigger. Because yes, you might have an underlying predisposed gene, but at the end of the day, lifestyle factors very much dictate whether the genes are going to go crazy and cause mutations and cancer development or not. So genetics is obviously relevant to this conversation. And then also just being a woman. I mean, women have on average much higher breast density, more breast tissue. So the chances of cancers popping up there are obviously way higher in women than in men, although men too can get breast cancer. Just FYI.
But a small percentage, right? I think it's only 1%.
Yeah, exactly.
Of breast cancers.
Yeah, it's 1% literally. Then age, I think, is also a super important factor here. So just at increasing age. And I think this, to kind of circle back to what I was saying earlier, I think this is why we're detecting it more, despite great advancements in screening and medicine, is because people are living longer. And the longer you live, the older you are, the higher likelihood of mutations forming in the cells and problems being when it comes to cell division and mutation formation and then subsequent cancer formation. So the older you are, the higher the likelihood of you developing any cancer, including breast cancer. And that is also why we are seeing it on the rise.
But it is also happening in younger populations. I mean, I've seen recently a lot of people in their 20s that are getting breast cancer. So I think that's something also to think about with the screening, right? Because a lot of mammograms and stuff happen once you're in your later 30s. You don't have access to that. So we'll get into that in the screening when we talk about screening. But I think it is important to note that, you get older, that is a risk factor, but there are still a lot of people that are younger that are also getting breast cancer.
And I think that's when we talk about the genetic predisposition, that's where that plays a huge role. I think the likelihood of you having a genetic predisposition if you develop cancer younger is where it's likely higher due to having a genetic predisposition, but perhaps not always the case. I mean, as we are elaborating on now, lifestyle also has a huge role to play. But then, in addition to that, there's also family history. Just having a family history alone increases the likelihood. And we talk of a first degree relative, which is essentially a parent or a sibling. So if someone in the family, a very close family member, develops breast cancer, then that significantly increases your risk of developing breast cancer. And you should start screening earlier, and we will certainly touch on that at a later stage.
And second degree relatives, what do you mean by a close relative? Right? Because I know we touched on this in the genetic part, but it seems to differ by country. It's almost like your mother, your aunt, your sister, etc. But or your grandmother, your maternal grandmother, but not your paternal grandmother, right?
No. So that's not actually true. So first degree relatives, as I was saying, is a mother, so a parent, so mother, or a sibling, or sister, or brother. I mean, the 1% of chance if a man's going to get it. But first degree relative is a parent or a sibling, whereas a second degree relative would be a grandparent. Okay. And yes, it is significant, and it's important to know about it if your grandparent had cancer. But it's obviously carries a way higher risk of you developing breast cancer if your first degree relative had it compared to your second degree relative. There's definitely still a risk, but it's not as high risk. Now, touching on the paternal maternal one, it's actually equal. So whether your paternal grandmother has it or your maternal grandmother, yes. And where this is very interesting is the age of onset of the grandparent. So as I said, if the grandparent succumbs to breast cancer late in life, advanced age, like they're older, then that's not so significant. Whereas if the family member developed the cancer early in their lifetime, that definitely is something that's relevant for us clinicians to know about, because then it implies that it carries that genetic predispositions not attributed to age.
Interesting. So I think we spoke about this in one of our episodes, and I think I did mention it. My grandmother actually passed away from breast cancer, but she had breast cancer when she was, I think, in her 40s, if I'm not mistaken. So a bit older, not necessarily much older in life, but still older. She went into remission she went into remission for a long time, and then it came back. Long story, doctors actually didn't believe her when she said, I think the breast cancer is back. They gaslit her and she couldn't go see a specialist, and it metastasized, and it was unfortunately too late. Sorry. But in France, when I spoke to my doctor about it, like, I wouldn't be considered a high risk candidate because they say it's my paternal grandmother. So it's really interesting that you say that, and something that I'd love to definitely need a challenge with them.
Yeah. Okay, no, I think you should take that up. I mean, from my research, it's, whether it's paternal or maternal, it's equal. Yeah. Yeah, and the fact that she had it at 40, I mean, is significant. Definitely something that you should look into when it comes to your personal screening, for sure. Something to flag on the history. But then also, just to elaborate more on the risk factors. So smoking, I mean, pretty obvious, but that means it's a risk factor for the development of most cancers because it affects the DNA. It increases the likelihood of DNA mutations occurring. And then alcohol, I mean, you seem to read up quite a lot about that. I'm curious to know what you read, but yeah, I mean, you were onto something, and it's definitely holds truth to it.
I mean, generally alcohol is not necessarily a good thing, although they say a glass of red wine is very good for antioxidants, makes you live longer. But I debunk. Tarryn's not on board, although she does love.
I mean, don't get me wrong. So. I enjoy a glass of wine myself every now and then, but I mean, I will never advocate for it on this platform. No alcohol is good for you.
But it was actually just saying, like, any alcohol increases your risk. Any unit of alcohol increases your risk of breast cancer specifically. And do you understand why that is the case, or what's the mechanism behind it?
Yeah. So alcohol, it's thought, almost mimics estrogen in some ways, especially in cases of estrogen receptor positive breast cancers, because you get different types. Some are hormone receptor positive and others are not. We don't have to get into the details of that, but alcohol does have some estrogenic effect and basically binds to the cells in a way that estrogen would and cause like cell proliferation and what have you. So basically it indirectly raises the estrogen levels in the body and promotes breast cell proliferation as well as tumor growth. But and then when it comes to like how much is considered significant, they actually say even if you have like a glass a day, that increases your risk by like something like 10%. So something just to keep in the back of our minds while we enjoy that glass of wine. No, but like at the same time, we also have to live our lives, so I'm not a nun. Like I know what it's like. Like I also enjoy a glass of wine, but I think just don't drink excessively. Like that's the bottom line.
And then childbirth and everything, because I think there's something actually to try, like take a step back and something to mention. Breast cancer starts right inside the milk ducts or the milk producing lobules of the breast, right? So I think that's quite important. That's where the breast cancer, the tumor develops, and then it can kind of expand out.
Yeah. Well, you get so many different types of breast cancer, and I suppose their pathophysiology is all different, like with regard to where they originate from. I'd probably challenge that they all develop from the ducts. I mean, they could also arise in the breast tissue itself.
Interesting. I had read that they all actually originate from breast cancer cells begin in the milk ducts and or the milk producing lobules of the breast. And then it spreads to the rest of the breast tissue. And that kind of brought me onto the question around like lactating, so like breastfeeding and everything like that. Because what I was reading is that if you breastfeed, it actually reduces your risk of
it does.
breast cancer. So I was just wondering if that's because breast cancer cells originate within the milk ducts. And then why would it be that if you have a child after 30, you increase your risk of breast cancer, but then if you have no children at all, you also are at increased risk of breast cancer? So I thought that was something that was really interesting. And I was just wondering if that had to do also with kind of the where breast cancer cells originate.
Okay. Yeah. Well, I was aware that breastfeeding has been shown to decrease the risk. But when it comes to childbirth and pregnancy, it's very interesting to touch on. But before we do, I think to have an overview idea of the science behind it, let's just take a step back and challenge early menarche, late menopause, because it's relevant to the conversation. And basically, there's something called an estrogen window, and this is the duration of time that a woman is exposed to high levels of estrogen in the body. And this typically sets in menarche when a girl starts menstruating, right? So if she starts menstruating early in life, it means that she is exposed cumulatively over the years to more menstrual cycles, more estrogen fluctuations, high estrogen levels. So if you have early menarche, it's considered a risk factor. And the converse is true for later menopause, because then you have like more reproductive cycles over the lifespan and a higher cumulative risk, okay, of the estrogen exposure, the estrogen window, as we call it. So with that knowledge in mind, I mean, it's actually, these questions are quite deep. I'm not going to lie. They're very nuanced. When you're pregnant, I mean, I was thinking, well, the estrogen levels are like fairly high even in pregnancy. So surely that should also like increase the window. Like, why would pregnancy itself be protective? Because it has been shown to be protective.
But under the age of 30, right?
Well, pregnancy in general is like known to be protective as well. But yeah, it has been illustrated that if you delay pregnancy till after 30, it's because of those increased menstrual cycle estrogen exposures, right? So that's what's actually setting the risk, okay?
It's very technical. It's very, and I think that brings us on to hormones, right? And that brings us on to why the pill or estrogen or, and I have heard also when you do get to menopause, it's actually like hormonal treatments for menopause with estrogen and progesterone that can put you at higher risk also of developing breast cancer. So curious to understand then that role of hormones. Estrogen more specifically, I think has always been linked to breast cancer, but is it just estrogen? Is it also progesterone? The pill, IVF, the injections you do, everything like that. Like how does that also link?
Okay, there's so much to unpack here. I'm going to try to do this topic justice. But yeah, let's just break it down into the different categories. We'll first touch on the pill, and then we'll touch on the menopause replacement therapy used in perimenopause and menopause treatment, and then we can touch on fertility treatments, if that's okay. Okay, so the pill. Does the pill cause breast cancer? Okay, the short answer is no. Okay, let's just get to the bottom of it. The short answer is no, and let's quickly tap into it. So several studies indicate that recurrent use of the oral contraceptive pill, which is typically combined with estrogen and progesterone, is associated with a slight increased risk of breast cancer. However, the overall absolute risk remains very, very low. So it's almost like a yes, but no. And you have to look at the bigger picture. So especially considering the widespread use of oral contraceptives that's been commonly prescribed like everywhere in the world, if you actually compare that with the incidences of breast cancer, it's very difficult to pin it down to the use of the oral contraceptive pill alone. I mean, studies have looked at this, and the absolute risk is so low that, just to throw some numbers in, taking hormonal contraception between the ages of 16 and 20, it is associated with an increased risk of breast cancer, but the increased risk is 8 per 100,000 women. Okay, that's super, super low. And then for those between 25 to 39, that increase is even it's a little bit higher. It's 265 per 100,000, which translates to something like 2%. So,
but if you couple that with, I don't know, genetic risk factors, other lifestyle factors, I mean, it all kind of adds up, right?
Sure. And that's why before prescribing the pill, I mean, it is relevant to know the family history. I mean, if there's a very strong family history of breast cancer, I myself as a provider will definitely counsel the patient. It's a combined joint decision, but It's not a complete contraindication, but it's definitely something to factor in. And maybe like you could opt for a lower dose oral contraceptive pill just to kind of combat that. But at the end of the day, use of the oral contraceptive pill, interestingly, is protective of ovarian cancer, uterine cancer. So all other cancers, taking the pill actually reduces that risk. So it's kind of like, and another thing is that it can have many positive effects. We do know that estrogen is good for the bones. It is linked with good cardiovascular health, the vessels. So it's kind of like a risk benefit type of thing. It's a very nuanced topic, and every patient needs to be extensively counseled on the risks and benefits, and the contraindications of each patient definitely has to be carefully reviewed. But when it comes to breast cancer, like when I looked at the up-to-date guidelines, the overriding consensus is no, it does not. It's not associated with significant increased risk of breast cancer. That's my take on that. And then even if there is that slight increased risk, it actually stops the moment you stop taking the pill. So it's only like when you are taking the pill. The moment you stop it, it's not going to have like that everlasting risk. Okay. So that was very interesting for me to kind of look into when it comes to cancer and the pill. When it comes to menopause hormone therapy, we recently covered this in the menopause episode. I suggest all our listeners go back to episode 4. We cover it quite extensively. But basically there was a landmark study done in 2002, the Women's Health Initiative study, which basically freaked everyone out and like freaked women into believing that estrogen causes breast cancer. But the study was really poorly done. And it was actually shown that the progesterone, the other hormone that's commonly supplemented with a dual combination with estrogen, the progesterone was actually what increased the risk, not estrogen alone. So everyone demonized estrogen, funnily enough. It wasn't even the culprit at the end of the day. And now, just looking at all the studies that's available to us now, we've arrived at the conclusion similarly that the absolute risk is very, very low for menopause replacement therapy as well, provided you don't meet the contraindications. And it actually can be very advantageous to women, especially if they're suffering, especially if they have really bad symptoms of perimenopause. It's really encouraged actually to go on such treatment, provided it's also within 10 years of menopause. So and typically under 60, and you don't have the relevant like contraindications. But I prescribe it quite frequently, and I always counsel the patients on this very, very, very small hypothetical increased risk, but it's very low.
It's interesting because when I was looking at, for example, like the Mayo Clinic, and I was looking at risk factors for breast cancer, the contraceptive pill was not something that was called out as a risk factor, but hormonal replacement therapy was. And I've seen that in a couple of different places that it is actually somehow. So I don't know if that's just like legacy stuff, that maybe it's a topic that comes up more often, or... Yeah.
I think it's the legacy of the WHI study. But even in that study alone, I mean, if you actually look at the stats and the science, it was subsequently concluded on further review that the absolute excessive risk is very low in young women taking the combined therapy. And there was even a reduced risk in those that just use the estrogen alone. So without progesterone.
And fertility treatments?
No. So I did look into it, and fertility treatments, there's no conclusive evidence that fertility treatments predisposes an increased risk of developing breast cancer, according to the studies. Yeah, no links or nothing yet conclusively demonstrated.
Okay. I think it'll be interesting before we kind of go into screening, when you should screen, how you should screen. We've spoken about the risk factors. Just kind of talking about, before we jump into that, the stages of breast cancer. So it's something that's thrown out a lot, that you're in stage 2, stage 3, stage 4, etc. Can you just break that down a little bit? What are the different stages? Like when the cancer metastasizes, when it spreads elsewhere? Because I think that's also like a helpful way to kind of break down and understand kind of some of the words that a lot of people often speak about. I have stage X breast cancer and stuff like that. So just before we dive into the screening, I think that would be something helpful to just break down.
So typically like it's graded from stage 1 to stage 4, and stage 1 being very early and hopefully treatable, and then moving to stage 4 where it's metastasized, spread around the body. So usually stage 1 is confined to like a small place. It can be either excised or targeted. And then stage 2 and 3 is when it kind of spreads a little bit more around the breast, and then can extend to the lymph nodes. by the time it's metastasized, it's in the axillary lymph nodes, which is in your axilla, and then it's also spread elsewhere in the body, other sites. The bone, it often goes to the bone, the liver. Those are two common places. And I think that's, a basic overview for our listeners, what they need to know.
So, I mean, you were talking about the lymph nodes and stuff. One thing I have read is that actually really early, like stage 1 breast cancer, you don't necessarily have symptoms. It's just that you may see certain changes if you do the self-examination. You may see like indentation. You may see kind of your skin changes and things like that, but you won't necessarily have pain that comes with it, which I think is really often associated. But when it does kind of then you maybe will start feeling it elsewhere. Let's actually talk about some of the signs and what to look out for, and then jump into the screening.
No, fair enough. Yeah, I think almost everything you said was right, but except for the fact of the pain. So this is something very important for our listeners to know. Breast cancer is commonly painless. Okay. So it's a painless lump. Yes, you mentioned the nipple retraction, changes in the skin surrounding the nipple, the areola area. There might be a bloody discharge or a discharge that's like off, out of keeping. You might feel some lumps in the axilla. I mean, that's usually when it's stage 2 or beyond. And there might be some like eczema, like just like weird, like skin discoloration around the nipple. Those are like the main hallmark signs to look out for.
And let's dig into the screening. When should you start screening? Self-examinations, mammograms, all of this. Like what is available? What's out there? Who's it available for? When's it available? What can you do yourself to make sure that you know your body and you can be your own best advocate? Because that is often the way that, lives are saved, by people understanding their own bodies and advocating for their own health.
Yeah. So different countries, different screening protocols. I'm obviously speaking with reference to South Africa. Generally, well, firstly, to answer your question, what can a patient do to advocate for herself? The first thing is to know your personal risk factors, your family history. Okay, that's like so important, and it's relevant because if you have a very close family member who had breast cancer, that really does change things. But provided you don't have that risk factor, 40 years old is the average age for mammography, okay? Which is a screening tool that's used that basically like hones in on the breasts and takes a deep dive into the breast tissue and tries to pick up if there's any like early lumps, okay? Sometimes that you can't detect with self-screening alone. When it comes to screening of the breast or just doing like self-examinations, sometimes it might lead to overdiagnosis. So the guidelines say that's like not the most helpful, but I would argue, like I disagree with that. I think in a country like South Africa that's developing, and not everyone has access to all these like fancy screening methods, not everyone has like fancy medical aids, and sometimes the medical aids don't cover it. Like I would argue it's always helpful, even once a month, just have a look at your breast, stand in front of a mirror, feel around, look and notice if there's any changes in the skin color, the dimpling, or the nipple retraction. Just like have a feel in the axilla. I don't think there's any harm in doing it. And I mean, if you're concerned, go reach out to a healthcare professional who can then make that accurate assessment. Okay. So I'd say even from the age of like 20, like do it once a month. And the best time to do it would actually be straight after your period when your breasts are not as swollen, like there's less swelling.
I'm glad you say that actually, because I was really shocked when you had mentioned that self-screening is no longer advised. I was really shocked. And then, I mean, yes, there are testing things available, but even developed countries, US, etc., they very much advocate for self-screening, testing, knowing your body. So I'm completely on the same page with you. I think it's hugely important to do your own self-examinations and everything. And especially because people don't also have access to a lot of doctors. And if screening also starts at the age of 40, if you get breast cancer younger,
100%. 100%. I mean, I was kind of citing an up-to-date article that I was reading, but that was mainly pertaining to developed countries where it's like, oh, there's like way too much over screening. And then we're like basically ultrasounding everyone because basically if you're under 30, you're not going to just go for a mammogram. Okay. Mammograms are for screening. Okay. So basically screening, what does that mean? It's you're trying to pick up something that you hope it's not there. Okay, it's like a preventative thing. Whereas if something's there, you're not going to go screen for it. Like it's there, you have to actually investigate for it. So in other words, maybe do an ultrasound in combination with other methods, or do a biopsy, or, kind of see what is this mass, but you kind of want to pick it up before you even get there. So generally speaking, I mean, I commonly encounter women of reproductive age come to the clinic and they have masses, and it's good that they come, because like we as healthcare professionals, we must make that assessment. And often what I end up diagnosing them with are fibroadenomas. Now, these are benign breast lesions, so they're not cancerous. They're very unlikely to form cancer, but they do require a little bit of monitoring. And, if in doubt, the clinician will send the patient, if she's under 40, for an ultrasound, which is basically a 3D view of the breast tissue. It can help differentiate cystic lesions, which are typically fluid filled with solid masses, and then perhaps they could also have a biopsy, like a needle go in, just to have a closer look and refine exactly what that mass is. But the reason I'm mentioning is it's just like I don't want everyone to panic. If you do feel a lump, it more than likely is a fibroadenoma. Of course, go and get it assessed. Let us confirm that, but 99% of the time it is that. But yeah, it's good that women are feeling their breasts and that, they're coming in. And even if it is for that reassurance, it's great. And fibroadenomas, I mean, they also require like annual monitoring just to see if it gets bigger or if there's any changes. And yeah, so it's good that women are empowered these days and they come forward with their symptoms and they have healthcare professionals just, back them and, like not gaslight them. So I'm really happy to see that.
And what else? What other screening is available? So you mentioned mammograms at the age of 40. Anything else? I mean, I know BRCA1 and 2 we spoke about in the previous episode.
Sure. So mammograms at the age of 40, unless you had a close relative who had, so a mother or sister, for example, who had breast cancer, then you start going for your mammos 10 years earlier than the age of the onset of the cancer of the relative. Okay. So that's why you must know your personal family history. And also genetic screening is widely available these days. It is quite like niche. Unfortunately, it's not offered in states, but definitely chat to a healthcare provider who can go over your risk factors with you and refer you accordingly to a genetic counselor. And also something like I just want to take back from the previous episode that we recorded on genetic screening. I might have mentioned that you need a referral from a doctor. It actually turns out that you don't, because I subsequently spoke to a genetic counselor. I spoke to a few even before, and I don't know, some say that you do, some say that you don't. But basically, if you're concerned and you want genetic screening, definitely go to our Instagram page. I listed quite a few healthcare professionals that offer it here in South Africa, and then you can maybe just inquire with them whether or not a referral is needed. And if it's not needed, go and book it, especially if you're concerned.
So what happens? You do the mammo, or you do your screening.
Yeah.
I think we kind of touched on it. What happens when you do get like an abnormal result? You're sent through for an ultrasound, you mentioned. Anything else that people should be aware of?
Yeah. So, well, firstly, don't panic, okay? Because often mammos, even if they come up with like an abnormal finding, don't panic yet, okay? You can only really look at the full clinical picture in conjunction with further testing, like an ultrasound to, have that wider 3D view that can like further hone in on the breast tissue, and then have like what we call a tissue biopsy diagnosis with like a needle that goes in and further examines that. But don't panic. Just check in with your healthcare provider, and the healthcare provider will lead you through the following steps. Something else, a question that I get asked a lot, and I don't know if this has like ever come across your radar, is radiation. Like people are like, I don't want to go for mammos because of radiation, and that's going to give me cancer. Like I don't know. Have you thought of that? Have you thought of that?
Okay, actually, good. I think maybe once I've heard about that, but I think it's more like CAT scans. But I think I have actually heard about that because I was pushing for screening and someone was like, yeah, but the radiation, actually the mammograms are the things that give you cancer. So
so just to kind of like debunk that, mammograms, they does emit a little bit of radiation, which is why we don't just blanketly do it on everyone. So if you are under 30, we'd opt for an ultrasound as first line screening. But the radiation that is emitted is so low that it's like almost negligible. Okay, just to put things into perspective, if you fly a long flight, like 6 to 8 hours, you'll have the same radiation exposure as if you as a mammogram.
Okay,
so I mean, if you're that concerned, don't fly.
But Tara, I think we covered so much. I know there's still so much that we could cover. Such important, such an interesting conversation, and I'm just so grateful to shed light on this topic because there's still so many women that are infected, and I was so shocked to see the disparity between the outcomes in South Africa versus other countries. So I think South Africa has a long way to go, and I really hope that we can continue to raise awareness in South Africa and that people can get early detection, because early detection saves lives. And I think that's
100%.
That's hugely important. The earlier you detect breast cancer, the more likely you are to have successful treatment outcomes. So I think that's hugely important. But thank you so much for those listening in. Please do not forget to hit subscribe. Please also do let us know what you think about us. Follow us on Instagram at The Ovarian Club. We would love to hear from you. We are preparing many more topics. As Tarryn mentioned, we are going to be talking about the pill as one of our topics, GLP-1s, etc. So really would love to hear from you.
Thank you guys so much for tuning in. It was great chatting as always, and we'll definitely see you soon when we discuss another exciting topic. The Ovarian Club, powering life, nurturing health, shaping sustainable wellness. We'll see you soon, follicle friends.